today. So I want to welcome you here. I'm Shirley Kessel. I'm the Executive Director of Miles for Migraine, and I'm really pleased to be able to bring this program to you all today. We have two very well-known speakers, and I'm sure many of you who have been with us before are very familiar with Dr. William Young from Jefferson, and we do have Dr. Wade Cooper from Michigan. And you probably know our topics, so I'm going to just jump right in. I'm going to actually put their bios here as a link into the chat, so that way you can go take a look if you have any questions about who they are and where they came from. And I want to thank our sponsor today, which is Teva Pharmaceutical. They are they're the reason we're able to bring this program to you today. So without further ado, I just want to say what we're going to do today is Dr. Young is going to speak first about stigma updates to us, and then we are going to just jump right over to Dr. Wade Cooper, who will do the treatment update, and then we'll be taking your questions. So please put your questions into the chat as they come up for you, and I will be looking for those questions, and I'll be pulling them at the end. So just put it up in there as soon as you're ready. So I'm going to, right now I'm going to mute myself, and I'm going to turn it over to you, Dr. Young. Share your screen.
Okay. Okay. I'm Dr. Bill Young, and I like to talk about stigma because I think it's really important, and I think it can be treated, although I guess that has to be proven. And these are my disclosures. And for me, my first sort of experience with stigma is when I was, very proudly presenting a poster on headache when I was a young attending, and another young attending, in a different area of neurology, was sweet and kind enough to stop by and to, visit, her colleague's poster, although it had nothing to do with her field of expertise. And as she left me, she said, "I'm glad you do headache. I don't like treating those patients." And that left me with a little bit of a bad feeling. I didn't really understand why. But I think I understand a little bit more now. So what is stigma? Stigma, is the concept that an attribute, a trait, or disorder, like a disease like migraine, but it could be the color of your skin or your sexual orientation, is deeply discrediting and may elicit some form of community sanction. So you're looked down upon and you're punished. So I think of those as the key elements of social stigma. And there are several types of stigma, and generally we break up stigma into three groups. There's structural stigma, which is in policies, laws, and practices. And to address that, we need to go to legislators and policymakers. There's public stigma, which are the stereotypes, prejudices, and discrimination. This is your mother-in-law saying, Tylenol works for me, I don't understand. That's public stigma. And then after sort of years and years of being exposed to structural and public stigma, unfortunately what develops, and this is almost inevitable, is self-stigma. Shame, low self-esteem, lack of engagement in treatment. It's just what happens to somebody who hears these adverse messages constantly. They may be very subtle. They may not even realize that they're hearing it. It's so much a part of the air we breathe. And yet it has these negative impacts on a person's self-esteem and ultimately, I believe, in for their health in a number of ways. And then there's a kind of stigma that is courtesy stigma, which is the version of stigma that I showed you at the beginning, where the stigma of somebody else flashes back, bounces back on the doctor, or the family member who takes care of it. So, years ago, you could imagine, somebody feeling stigma because their child had autism. Like that would be courtesy stigma, where you don't have the autism, but you feel the stigma of being the parent of somebody with autism. And just as an example of courtesy stigma. So, and this is another way of looking at it, and I just want to sort of formulate or think a little bit about the self-stigma process, which necessarily occurs. So as a result of thinking about stigma, one day I read a article that I was surprised you could measure stigma in neurologic disease. I had no idea, 10 years ago that was a thing you could do. And I was smart enough to be, a little bit ticked off that, these people who were measuring stigma were doing it in Alzheimer's and stroke and Parkinson's disease, and they neglected, the most important and the most, common neurologic disease, which is migraine. What was that about? So me and one of our residents set out to measure stigma, and what we found, and just as an aside, we compared it to epilepsy because there'd been a lot of work in the stigma associated with the disease of epilepsy. And what we found was that people who had episodic migraine had just as much stigma as the highly stigmatized epilepsy. This is in neurological clinics. It may be different in the population. And chronic migraine had much more stigma than epilepsy. Comparing, my friends down the hall in epilepsy with their patients with our patients in the headache center. So there was a little bit more. So, in our clinics, as I told you, chronic migraine was more stigmatized than episodic migraine and epilepsy, which were about the same. It was all linked back to the ability to work. And it was also highly linked to the mental component, to mental health symptoms. And that is a tricky one because, I think in the causal chain, you can say that ability to work, reflects more on the stigma than the stigma reflects on the ability to work if you have migraine. But for the mental health stuff, it's a little bit less clear. So I just want you to keep that in mind. And then, but it is compatible with that flow chart I showed you where, public stigma, leads to self-stigma, and that causes, decreased self-esteem and anxiety, depression, and so forth. And chronic migraine, if you took out the disability, so our chronic migraine patients had more disability than the epilepsy patients that we compared ourselves to. So when you took into account the disability, chronic migraine and epilepsy were the same, and episodic migraine a little bit less. And there have been a bunch of other ones, but like basically everything that's bad for migraine correlates with stigma. So disability, in this other study, disability, pain, catastrophizing, anxiety, depression, quality of life, it all correlates strongly with stigma, as does frequency and severity. But stigma contributed significantly beyond migraine symptoms and was independently associated with disability and emotion-related quality of life. So they too found that, stigma may have some kind of extra negative impact on, disability. I think they had the direction of causality a little bit wrong there in the study in the way they formulated, but certainly beyond what you would expect from the migraine symptoms. So we know a little bit about, who's the stigmatizer, and this is from, a large group of people, most of whom don't have migraine, answering questions, and, men are worse stigmatizers than women, non-white people than white people, younger people are more stigmatizing. Again, how people who don't necessarily have migraine probably don't, relate or think about people with migraine. Those who don't have migraine are more stigmatized. Those who fear pain, those who aren't very empathetic, are worse stigmatizers. Those who don't fear migraine, and lower income people. So that's those were the features of stigmatizers. Now, remember, this is just large groups. Somebody who was a woman with migraine, who expresses a lot of empathy could still somehow be a very bad stigmatizer. But as a group, that person would be less likely to be a stigmatizer. There was also a survey about, what people believe about persons with migraine. And a third of people out there believe that migraine is easily treated and due to a person's unhealthy behavior. So, I have to say that really has nothing to do with the patients that I see. And 3 out of 10 think that people use migraine as a disease to gain attention or get out of their commitments. That fits, and it feels like that should be right. But what was really problematical for me, and that people who knew a lot of people with migraine tend to hold more negative attitudes towards people who have the disease. And so why is it that knowing a lot of people with migraine may make you a bigger stigmatizer? I think I know, I can't really prove it, but I think it's explained, that people with migraine are only letting the cat out of the bag, that they have migraine when they can't do something, when they're bothering somebody else by it. And so, people end up seeing people with migraine as people who bother them because they're not doing what they're supposed to be doing, and the person who doesn't have migraine has to make an adjustment. And I think that if that's right, I think that may be, something that we can work on. And then this is a population-based study of stigma, and they've made a whole new scale. This group, the Overcome study, and they measured stigma, and according, and people who had more migraine days experienced more stigma. They broke it down into those 2 categories I showed you before. They people who they thought people viewed them as minimizing the burden of their disease, or that they were viewed as trying to get secondary gain. And those people who endorsed feeling stigmatized, according to both types of stigma, had much more disability. Again, showing this complex correlations between disability, between stigma, and between the symptoms of migraine, like how many days a month you have it. So the conclusions from this study was that migraine-related stigma is prevalent. More than 30% of people report experiencing stigma often or very often. They identified 2 forms of stigma. Others believing that migraine is not burdensome, and others believing that migraine is used for secondary gain. Across all monthly headache days, experiencing increased stigma was associated with poorer outcomes, increased disability, increased interictal burden. That's the burden when you're not having an attack, and decreased quality of life. And their conclusions was that reducing stigma may improve patient outcomes. People will get better, more better, if you treat the stigma too. Now, this is an amazing study. 108 or 106 diseases, and how stigmatized that disease is within newspaper articles over, I don't know, 50 years or something like that. And I just want to point out that, very stigmatized diseases, the most stigmatized are eating disorders, mental illnesses, addictions, and sexually transmitted illnesses. And migraine was way down here. And I did take a ruler and very carefully measure, and it's right on top. Migraine is right on top of gonorrhea. That seems pretty bad, pretty stigmatized compared to other diseases. And here's how migraine compares to other neurologic diseases. It is the most stigmatized of the neurologic diseases, and that was right. It's more stigmatized than epilepsy and all these other diseases that are neurologic. And here you can read the font, unlike the other stuff. And that's weird because migraine is extraordinarily disabling. You probably heard this, but and I've told you how the stigma relates to disability. And the problem is that migraine is almost by definition, in my opinion, a disease that causes disability. And migraine is number 2. And in terms of impact, which is a number that has both death and disability in it, migraine is number 14 in the world. And this was in 2019. The stigma relates to the disability, and migraine has lots and lots and lots of disability, and that's a problem. Because stigma has consequences. There's some evidence that the stigma itself, and this is hard to prove and very complicated to prove, but discrimination does seem to increase pain, which is a kind of stigma, and racial discrimination that this was the study. And I think that relates to increasing migraine symptoms and increasing disability, and you get a ugly feedback loop that worsens everything. And stigma has consequences because of stigmatized disease. Lung diseases are famously stigmatized, and migraine gets less research dollars. So another consequence of having a stigmatized disease that comes back to, bite the person with migraine on the posterior for having their disease is that, NIH and your government doesn't think you're worthy of getting research dollars allocated to you. And by the way, this is a logarithmic scale. So this distance is not 50%. This is like 10 times what it ought to be. So the distance from here to here is 10 times more than that, because it's a logarithmic scale. So this is really bad discrimination by NIH. And then Social Security disability, another consequence. people with migraine are apply for Social Security disability much less than the data predicts than they actually should, given how much disability the disease causes. People with migraine are unlikely to even apply for disability, and despite this, there's a very low rate of acceptance for the disability. So that's in the 13th percentage in acceptance, for all diseases, even though, people with migraine have been, trying incredibly hard not to apply for Social Security disability. So, migraine has a lousy frame. Another important aspect of the stigma, or the frame, that's another way of looking at it, is that it's seen as an easy to treat condition of white middle class women who typically can't cope. It's a metaphor for something that's irritating but not really serious. In scientific presentations, the migraine brain can't handle stress, kind of feeding back on this negative metaphor. But it doesn't have to be this way, because in the 1700s, migraines went from a very neutral, unstigmatized frame, as far as we can tell. Like reading any text before that, there was nothing really particularly negative said about people with migraine, and it was just as stigmatized as if you had tuberculosis or a broken bone. You still were, you were treated about as well or poorly as someone with those other diseases. But then it very suddenly changed. And so, there's a famous poem by Alexander Pope, in which, Belinda's hair is protected by a host of magical creatures, and a baron slips through all the defenses and cuts a piece of her hair. And here's how she reacts to getting her unwanted haircut. She sighs forever on her pensive bed, pain at her side and megrim at her head. So here's this very widely read, poet. It's sort of maybe like having, like a tweet storm against people, making fun of people with migraine might be a good, or TikTok, making fun of people with migraine in those days. And, everybody had a good chuckle over that. And then, half a century later, they used to have these things called masks. And in 1782, a character, a person dressed up, to this mask, and there were like prizes for having the best costume and the funniest costume, gliding his way past the Venetian sailor, the gentleman in a coat of two different colors, and the usual unremarkable costumes of some 800 attendees. The high German doctor had a dashing figure. He introduced himself to the gathering as Le Sieur Francois de Migraine, doctor on medicine. So, he's making fun of, patients with migraine and the doctors who take care of them, as, endorsing the emotional, unnecessary disability and seriousness of the migraine patient. Kind of very mean and ugly way of saying, of looking at things. And Joanna Kempner, the patron saint of migraine stigma, wrote a whole book about how, the stigma of migraine sort of has a female flavor. And, I like to think that women with migraine are stigmatized for having a women's disease, and men with migraine are stigmatized for having a woman's disease. why, and the historians really don't like it when a mere neurologist, speculates about an important historical observation, but I have to fill the void. Like, what changed in that time in history that led to this dramatic turnaround? And I think one, it was the age of reason. So, diseases where you could, find a pathology, a broken bone, later an X-ray, a tumor, junk coming out of your lungs, you could understand that. Migraine, they couldn't understand in those days. It didn't have a reason, and in the age of reason. And then the other one, is, well, the clock was, invented, in 1200 or something. I think that this was the time when people started to have to live by the clock, when there was a clock in every village, and when you had to come up, and go to work in the bank or something, at 8 o'clock in the morning. And it was the new industrial world wasn't very kind to people who had to stop because they had a migraine and would catch up later. And so they were really at a disadvantage, and they in this new world run by the clock, they inconvenienced others, and they started to get stigmatized. So we had a symposium called Shut the Door on Migraine Stigma Symposium. And this is what we concluded is probably right. How do you prove this stuff? Number one, from the mental health, we need to disclose migraine. We need to do, we need to not hide it, and we need to think about how we disclose our disease. We need to, bring out empathy towards ourselves and in others, empathy towards people who have migraine. The disability is the key. Like, it's fundamental to migraine. People out there need to learn that it is normal for a person with migraine to not be able to do certain things on certain days. That's just what the disease does. Emphasizing brain disease, well, it might, as a policy, as a way to change things, it isn't going to help. It may help, the doctor, feel they're doing a good thing, and the patient a bit, but there's a big policy saying it's a brain disease isn't gonna help. Now, I think saying that it's a disease will help. But saying it's a brain disease, it doesn't help at all. New frames can harm if you try to say something, to reframe how people view migraine to reduce stigma. You should think about it very carefully. It's not a spur of the moment decision. Mistakes can be made that are bad for us, for people with migraine and the doctors who take care of them. Patients have to be the ones who destigmatize the disease. It doesn't happen from doctors. You patients have to destigmatize migraine. It's not going to come from doctors. Actions, different kinds of things are needed for structural stigma, enacted stigma, internalized stigma. For all the kinds of stigma, you need to have an appropriate attack on the stigma. I think language, sort of underlies all of this. So the Coalition for Headache and Migraine Patients has adopted these recommendations. Call it a disease most of the time, if it's disabling, call it a disease. It is a disease. Don't try to, pretty it up and say it's a disorder or a condition. Don't say migraines. That makes you think about the attack and not the chronic, that it's a chronic disease. You don't say asthmas, you say asthma. Don't say migraine headache. Migraine has a lot, headache is only one of many symptoms of migraine. And, unless you're specifically trying to make a tribe of people with migraine, or, person with migraine, is the right way to say it. Certainly for doctors, patients have a right to choose whether they want to view themselves as migraineurs, but person with migraine is what we recommend for doctors, and I think for most patients. Don't say sufferer, you can have bad migraine and you don't want to be seen as a sufferer. And migraine personality, migraine type person, all of that has to go. And medication overuse headache is an ugly, stigmatizing term. Rebound headache is a little bit inaccurate, but it's something that you can code. Dr. Cooper, you can code rebound headache instead of medication overuse headache. And medication adaptation headache, is something that may not be well understood, but it's probably a better, more accurate choice if we can get this accepted. That was so further learnings. I've thought since the Stigma conference, I thought a little bit more about this, and I think we need to learn how to confront somebody. I confront my patients about stigma and self-stigma. To do that, you have a chance to frame it. That's what the elevator pitch is about. You ought to have a bunch of elevator pitches for the common scenarios where, but you're never done. Like, don't say like, I'm done, I'm good. There's always got to make it better. Migraine disability is common, normal, and not someone's fault. Migraine stigma may be improving a little bit. There's a little bit of evidence that we may be heading in the right direction with this. And then, of course, the most important thing you can do is support Miles for Migraine, go to activities, go to walk runs. Absolutely critical. And I'd also like to give a shout out to the Alliance for Headache Disorders Advocacy. Its walk run is virtual and it's in June. And I have been a part of that organization. I did my time as president. And just to some of the issues that I think it might be interesting to hear, the policy issues where, I think by addressing these, we're also attacking the stigma. NIH funding, accounting migraine, they didn't even bother to measure like how many grants had anything to do with migraine or headache. Fair grant review, oxygen for people with cluster, research in the HEAL, where there was a law passed with money from addiction that went to doing pain research to reduce opiates and addiction, Social Security disability, VA, veterans, and Indian Health Services, centers of excellence for migraine, migraine in the IDEA. That's so kids can get IEPs if they have disabling migraine disease, and we're trying to get a congressional migraine caucus. So those are some of the important policy issues that are we're way behind on because of migraine stigma, but our community is trying to correct. And I'd like you to imagine a world. Well, at the first meeting of the Stigma Committee of the Coalition for Headache and Migraine Patients, all of the patients said, like, let's do kids, because the stigma starts with kids. And they all had a story of how they were stigmatized, in school when they had a migraine attack. They developed the migraine at school, and the state of Utah adopted migraine at school. And there are materials for kids, for parents, for teaching, lesson plans, and there's screening through all the schools in Utah, in middle and high school, to diagnose kids who have migraine. So imagine a world, where kids are taught about migraine disease. They learn that it's a thing that doesn't have to be stigmatized. It's not weird or embarrassing, and that they're treated matter of factly and with good kindness, care, best practices, and it's a normal thing to have migraine, and we'll do the best we can. And that's my talk. So I'm sure I went over. I wasn't even looking. Shirley didn't text me, I don't think, to tell me I was talking too much.
No, you're good. It's all good. It's fine. We actually, Dr. Cooper has been answering some of the questions in the Q&A, so it saves some time too.
Okay.
I just want to also mention that I put in the chat that Miles for Migraine has an advocacy training program. So it's called ACT Now, which stands for Advocacy Connection Team. And so please take a look, click on it in the chat and consider joining that program, where you will learn more about stigma and how to overcome stigma with friends, families, coworkers, whoever, and also learn how to know everything there is to know when it comes to advocacy. Okay, thank you very much, Dr. Young. If you want to unshare, we will transition over to Dr. Cooper, and you can continue to put your questions in the Q&A. Since Dr. Cooper will be presenting, we will just read the questions. I'll read the questions at the end of his presentation. And if you have any other questions for Dr. Young, please put those also in the Q&A. So with that, Dr. Cooper, it's all yours.
Thank you. All right, great. So here's my disclosures out there. My name is Wade Cooper. I'm a headache neurologist. I've known Bill Young for a long time. I've been in the Bill Young fan club for quite some time, actually. I'm the secretary currently. I was talking to my kid. I've got 3 kids, but one of them is 12 years old. He was in the back seat with his friend talking about superheroes. And they were talking, he wanted to be like the weather dominator superhero, and his friend wanted to be the time change superhero. And I was thinking, what would a champion of migraine superhero look like? And certainly, let me get rid of this here for a second. Certainly you'd expect, skin tight, ripped biceps and ripped abs. And then you'd also expect someone to be super knowledgeable about migraine and knowing how to help people with migraine, but also like a tremendous advocate for people who have migraine. But even beyond that, if we're talking true superhero type, we need someone to actually be a mentor to young people and bring more newer clinicians into the world of migraine. And I don't know how many, fellows someone like Bill Young has had, but I would just like to say he's our superhero for migraine, because what you guys know of Bill Young is a gentle headache neurologist who knows everything that I've ever thought of for migraine. But what I know of Bill Young is he's a tremendous mentor for the field of migraine for physician development. And I just think that doesn't get the recognition. Everyone loves Bill for being Bill, but that's another piece of what Bill does behind the scenes in the typical Bill Young way. So he's our hero of migraine in our world. And my job is just to give a real basic overview of what the migraine world looks like from a preventive therapy. I'm going to cover some of the older preventives and talk about some of the secondary benefits they may have. This is from the International Space Station, just giving a general overview of the United States. And then I'm going to focus on some of the newer therapies. I'm going to do this all in 25 minutes. So less in like fancy detail, but more about general concepts, things that you might be able to talk with your providers about, or just to kind of provide some background information in case you're curious about that. There is someone in the chat, I think someone had asked, I think his name was Sam, and he was asking about how he can understand migraine better for his significant other. And I think that's pretty cool because migraine is super common. First of all, there is a study done, talk about stigma. There's a study done in South America. And if you include people who qualify for migraine and people who qualify for probable migraine, that means you don't have all the bells and whistles to qualify for a true diagnosis of migraine, but you have some of those features like headache plus some light sensitivity on an every now and then basis. There's actually more people in the world who qualify for migraine or probable migraine than there are people who don't. So the weird ones are people who don't on rare occasion have a migraine experience. And migraine is this complex neurologic disorder. It affects the linings of the brain where there's a swelling and inflammation that happens. And this generates things like headache and nausea and makes people incapacitated at times because the central effects of migraine, such as concentration deficit or fatigue or nausea, in addition to pain and light and sound sensitivity, drops down people's ability to function. And that's certainly a big deal. And if we talk about head pain anatomy, about how this relates to things, we know pain signals come from the lining of the brain. That's part of the circuitry of migraine. Those pain signals come through these big ropey nerves in the skull called the trigeminal nerves, and then feed into the brain itself. And that's where your body processes nausea and light and sound sensitivity, but also processes clumsiness, which some of our patients have during migraine, also processes the cloudiness that people have during migraine. And it spreads to all these different fancy areas of the brain, including the hypothalamus, which is our sleep-wake cycling, our feeling hungry, our feeling stressed out type centers of our brain. And this is a two-way street. So if someone has poor sleep or doesn't eat well, or has my in-laws come visit, that's a well-known migraine generator. It kind of does that. And I don't want you to know this stuff about the brain. I'm just trying to show off a bit here. Just trying to show you all these connections in the brain and what migraine is. It connects to alertness, it connects to nausea, it connects to your sense of weather fluctuation. There's questions in the chat about barometric pressure. And not only is there pressure in the ears and barometric pressure, but there's an effect on the area of the brain that regulates our response to seasons and day-night weather changes that's central, which is why sometimes just an ear pressure bud's not going to fix the whole problem. And I mentioned a little bit in the chat there. So this, don't know this slide, just know that migraine's complex. It's not just a headache. And we've been fighting the stigma for such a long time. And Bill nailed it. He said sometimes people have a low-grade tension headache. They take an Advil or an ibuprofen, they feel fantastic, you know, and they're like, what's wrong with you? But people who have migraine, it's kind of unfair. They have this enhanced nervous system. And we know they're enhanced because at baseline, people with migraine have better sense of smell, better sense of taste, better sense of hearing, better sense of vibration in their bodies. Their nervous system is enhanced. The problem is, in a flare of migraine, that volume switch goes way too heavy and the body doesn't know what to do with that signal. And you start going into these shutdown episodes and people get sick from it, which is not good. Now, I want to talk about preventive therapies. That's the job I was given by the great Bill Young. And when we talk about preventions, there's lots of areas to think about. We think about targets. You know, we know there's targets on the lining of the brain. That's where anti-inflammatory medicines go work at. That's where our newer, fancier medicines called CGRP therapies, we think, work at. That's where things like neurotoxin has its effect. We also know that the trigeminal, the ropey nerves bring in pain signal, is where we think the triptans, acute therapies for migraine work, a few other medicines work there. And deep in the brainstem is where we think some of the anti-inflammatory meds might work, where we think some of the dopamine medicines like Phenergan and Reglan and those kinds of things, but also opioids and barbiturates, and sometimes even neuromodulation can work in there. And we know this, but also, and I want to focus now a bit on the lining of the brain again, because the cortical membrane events, the nerve to nerve pain signaling, is where we first start our journey for preventive therapies. If you're going to help someone with migraine, don't be this guy. This is a wedding. He's asked to bring up the rings. Oh no! Instead of trying to help, he bop people into the water. And you better believe the wife will never forget this moment ever again, nor will the priest, because you want to try and help, but you got to know what you're doing, right? And this is an important aspect. Favorite part of this video is the priest's eyes. I know it's blurry, but boom, that guy's going down later in the night. So that's how this works. So the first thing is nerve-to-nerve irritability and transmission. I want to talk a bit about this because I know this is like a complicated picture. Here I'm trying to show a blood vessel. Here I'm showing a pain-sensitive nerve. Here I'm showing an inflammatory cell. And this is a cross-section on the lining of the brain. What I'm trying to show off here is that when a migraine occurs, there's all this inflammatory stuff that happens on the surface of the brain. This guy here, called a mast cell, is part of this mechanism, and it spews out all this inflammatory stuff that irritates nerves on the brain, and is part of why we see migraine generated in people who have proneness for allergies or proneness for other inflammatory issues in the body. And these are not friendly cells in the lining of the brain. These are things we call mast cells. I got a picture of them releasing here in a petri dish. This is like the holy hand grenade, if you don't mind that expression, because it releases not just CGRP or modulates CGRP, an inflammatory protein on the surface of the brain. It's associated with the release of histamine and a screwing up of your body's serotonin levels and a screwing up of the inflammatory things we call cytokines, or leukotrienes, the same thing involved in asthma or gut inflammation, or things that cause your body to feel achy and sore, like prostaglandin effects. So this is part of what we see as part of migraine. And people were asking in the chat about body pain and migraine. And this is one small piece of the big puzzle that we know about this stuff. And of course, one of the heroes out there right now is CGRP. It stands for calcitonin gene-related peptide. You don't need to know the name of it, just know that we've got targeted therapies that work on this substance as one of these inflammatory signals that causes pain. And I'll cover those in just a couple of minutes too, because CGRP doesn't just affect the brain by itself. CGRP affects the lining of our heart blood vessels. It affects the lining of our lungs. It affects our skin. It affects our bladder. And when CGRP is misbehaving, we can see increased signals of pain, not just in the lining of the brain, but also causing trouble elsewhere in the body. This should come as no surprise to the great Bill Young, but CGRP is related to spine pain. CGRP is related to abdominal pain or inflammation that we think is related to a concept of irritable bowel syndrome. CGRP is related to pelvic pain, which is known as painful bladder syndrome now. And some people believe CGRP is related to whole body pain or fibromyalgia. I can guarantee there's at least one company that makes a CGRP targeted medicine for migraine prevention that's studying fibromyalgia out there. So that's kind of like a general overview. Now a few specifics. Here are the vitamin therapies that we think of for preventive therapy. In our practice, we use a boatload of magnesium. It's kind of our Zorro. You know, someone's been to our clinic because we've jammed them full of magnesium. And I'd like to challenge anyone out there to show me any better research for nutraceuticals besides magnesium. I think it's the best studied. And we think magnesium glycinate may have given us the best research, but I think magnesium oxide would be fine too. I'm less excited about coenzyme Q10. I've had a lot of people try it. I just don't see the squeeze on that, but I know that's out there for published research of helping prevent migraine attacks. And then feverfew and butterbur both hail from the same family as ragweed. So if someone has a ragweed allergy, we don't recommend that supplement. I actually don't use a lot of that in our practice too, only because butterbur at one point was found to be a bit irritating to the liver. There's a few brands that boast not being liver irritating, but we don't use a lot of that in our practice. Now, the prescription medicines, I do want to cover briefly this stuff. You know, this is amitriptyline, and amitriptyline is old school. Amitriptyline is a medicine that was designed to be an antidepressant medication. It's still used for that at certain times. It's not the world's most powerful antidepressant, but it's used sometimes for that purpose. But it certainly can be effective in preventing migraine. It's a medicine you start off low and you gradually increase. It can give you side effects like a dry mouth. It can give you side effects like sometimes urine retention or dizziness when you stand up, but it also helps people sleep a bit better. So this is prescribed by primary care physicians, by neurologists, by everyone in between to help you sleep sometimes, as well as to prevent migraine. And we use it a lot in our practice. Now, remember when I talked about that inflammatory loop that's out there? Amitriptyline sometimes helps with inflammation. Matter of fact, its chemical structure is right here. Bill knows this. We call it a tricyclic medicine. Everyone in that whole family is called a tricyclic medicine because if you look at it under the microscope, it's got this weird chemical structure to it. Well, check this out. This is another tricyclic medication. It's even got this, what we call an amine group on the bottom of it here. But check this out. That's not amitriptyline. That's loratadine, the over-the-counter antihistamine medicine used for people who have allergies. And we know that histamine plays a role in migraine. We think it plays a role in poor sleep and sleep dysfunction in migraine. We think it plays a role in inflammation in the rest of the body. And sometimes the antihistamine effect of amitriptyline is what we think is helpful for people with diffuse body pain or migraine prevention. Something to think about there. Now, here's a famous old-fashioned medicine called topiramate. Topiramate is a very effective migraine preventive medication. Matter of fact, up until recently, it was king of migraine prevention. It was designed to be a seizure medicine, right? And when it came out as a seizure medicine, it was quite effective at doses of 400, 500 milligrams a day. At lower doses, 25, 50, 100 milligrams taken per day to prevent migraine, it can lower frequency and intensity of migraine. A couple side effects to know about. Sometimes it can increase your chance for kidney stones. No one likes that. And sometimes it causes cognitive issues. I had a patient of mine tell me, hey, wait, I can't remember the last time I had a migraine. I'm like, this is fantastic. They said, no, you don't understand. I can't remember the last time I had a migraine. And what they were really saying was that they may have had benefit in preventing migraine with topiramate. It's one of our best medicines out there, but a small number of people shunt the metabolism of this medicine to a byproduct that causes cognitive changes. And this person was having enough cognitive changes, it was impacting his quality of life. So certainly a no-go. What's curious about this is the ability to get cognitive issues on topiramate is based on a liver enzyme glitch that some people have more than other people do. And if you have the inability to break it down the normal way, you get the cognitive issues, which is why sometimes patients can be on like 400 milligrams of topiramate and never have a side effect to it. And other folks take one lick of one tablet and develop the side effects from it. Now, the next thing is, let's say someone says, well, topiramate was great, but it had all those side effects to it. There's zonisamide. And zonisamide is in the same family as topiramate. It's a medicine that has a bit less cognitive issues, but kind of works about the same way. This one, just like topiramate, has weight loss as a side effect. Matter of fact, some weight loss programs use zonisamide purely for weight loss. So for our patients who struggle with weight gain, sometimes this medicine might be an option. It comes to mind in headache syndromes associated with larger body size, like idiopathic intracranial hypertension is an example. This one also has a chance for generating kidney stones. You got to be aware about that. This one, just like topiramate, takes weeks to months before you know how effective it's going to be. So you just be aware that these are kind of tablet medicines that are out there. Now, the next thing I want to mention is beta adrenergic blocking medications. These have been around a long time too. Propranolol is the most famous for this. Sometimes it causes heart rates to be slowed down, and sometimes it makes people feel less energetic, but it has a secondary benefit to it. People who have chronic anxiety disorders sometimes find this helpful. People who live with autonomic dysfunction, which means their blood pressure and heart rate screwed up, even in our patients who have something called POTS, a separate but related neurologic disorder to people who have migraine, sometimes do really, really well with low doses of this type of medication. And I mentioned that propranolol is king. It's dirt cheap. About $4 will buy you 3 months worth of propranolol, even without insurance coverage. But they've got newer classes of these medications with less body side effects, in my opinion. This includes medicines like nebivolol, as well as Z-beta. These are medications that have lower side effects, but sometimes might be similarly effective. So if you feel like you may have done well before, but had side effects, that might be worth a discussion with some of your providers. And I have two other tablet medicines to mention. One of them is an angiotensin receptor blocking medication called candesartan. If you haven't heard of it, this one's a blood pressure medicine too, but it works very differently than the beta blocker class medications. As a matter of fact, if you don't have high blood pressure, it generally doesn't lower blood pressure in your body because it has to have too much of this thing called angiotensin around for it to be effective in lowering blood pressure. This medicine was compared in a head-to-head trial with propranolol and found to be about the same in power and seemed to be a bit better tolerated in our patient population. And in a headache preventive trial, lowered headache days, lowered migraine days, and the adverse events were similar to placebo. Last one of the old-fashioned medicines to mention. I know I'm going quick, but I really just want to be thought generating with these and not really going through nitty-gritty detail. But this is a favorite of our clinic. It's not a favorite of every neurologist clinic, but this is memantine, and memantine's been around for at least 25 years. It was designed and FDA approved for dementia, which means cognitive issues as people's bodies mature. But here's the thing, it blocks glutamate from irritating the nervous system, and glutamate is one of the key signalers involved in migraine. It's also one of the key signalers involved in diffuse body pain. I know people had some questions in the chat about diffuse body pain as part of migraine. And one model of that diffuse body pain invokes a centralization of pain in the rest of the body that uses, amongst other things, a glutamate signal. There's some people who use this medication for fibromyalgia, something we do in our practice too. And the thing about this is if you use it just for migraine prevention, there's at least 3 different articles that show it's effective in lowering migraine days and lowering impact of migraine. But the thing about it's also very inexpensive, and it works completely differently, we think, than medicines like topiramate or beta blocker medicines or valproic acid or the tricyclic medications. So we tend to use this a lot in our practice when people have tried other things without benefit, or people who've got a lot of centralized body pain. And the neat thing about this is there's very few side effects to this. You worry about dizziness, you worry about a little bit of feeling a bit spacey, but most of the time very well tolerated. So the problem with oral tablet therapies though is that they take a long time to work. Sometimes they can take a month, 2 months, 3 months, 6 months to work. We know about 50% of people stop medications within the first 6 weeks of oral preventive therapy because they're not seeing benefit or they have side effects. I mentioned a bunch of side effects to these tablet medications and people stop them frequently. And so we have things that don't have a whole lot of side effects, some of the newer concepts in treating migraine for prevention. One of them is onabotulinum toxin. Now, it's funny, when we first heard about onabotulinum toxin, people might know it by its brand name Botox. When we first heard about Botox, I thought it was kind of crazy. Then we started using it, and now no one raises an eyebrow. Bad joke there, right? But anyway, it turns out that this actually blocks the release of inflammatory CGRP in the lining of the brain. And we think that's part of why it's helpful in lowering frequency and intensity of migraine. The bummer with onabotulinum toxin is it takes about 31 pin pokes, although they feel like mosquito bites, to prevent migraine. By getting it into the nerves, it's absorbed upwards into around the lining of the brain and lowers this nerve-to-nerve transmission of inflammatory signal. But it takes a long time. Sometimes 3 months to show benefit, sometimes 6 months to show benefit, sometimes 9 months to show benefit. So if you're going to do it, you got to commit to it and stick to it. It's just what's required if you're going to be on that type of therapy. Now, here's the thing, so our patients many times will be just like this monkey here. It's doing the same thing as his partner over there. This is the stigma idea, right? Patients in the right side of monkey cage are people who have epilepsy, and they've got all this research to tell them how to fabulously treat their disease. People with migraine don't have that type of research. They get kind of the crummy, who wants this cucumber taste as opposed to a grape taste. And this is how they feel. It's not fair. Not fair at all, right? And as time goes on and we start rewarding other diseases and do all this fancy research, our patients and our clinicians feel just like this monkey over here. Why should they get the grape, the good tasting, fabulous therapy? We have just as impactful disease. We get horrible research sometimes. It's overall not fair. If you're going to give me that cucumber again, I'm going to go bonkers. Matter of fact, I'm going to go bananas because it's just not fair. Patients who don't get treated fairly feel it all the time. And our patients deserve targeted therapies for migraine because it's one of the most disabling conditions in the globe. So thank goodness we've made some moves on this. Here's that CGRP I mentioned before. And now we know with this inflammatory effect, not only in the lining of the brain, but the rest of the body, we can shut this down in certain ways. There's tablet medicines for this. There's 2 that are now FDA approved for preventing either migraine episodic or chronic migraine. One of them is called atogepant. It comes in 10 milligram, 30 milligram, 60 milligram tablets. One's called rimegepant, 75 milligrams. Now, I'm going to say brand names so you know what they are. Atogepant is known out there as Qulipta. Rimegepant is known as Nurtec. And both these guys, within the last 2 years, are approved for migraine prevention. Here's what we like about these medications. The clinical trials looked really good. If you respond to these, it's usually quick, usually within 4 to 6 weeks. If you respond, you typically maintain responding over 52 weeks. Side effects, some nausea, some constipation, but not a lot that drives people to stop these medications. There's no blood vessel squeezing down on these medicines. And we think that this medicine works blocking that inflammatory cascade I mentioned. There's no needles with this. So if someone hates needles, like a bunch of patients in my practice, this is something to think about. The second thing about this is that if you need to stop it because you got pregnant, or if you need to stop it because you want to move to something different, what else, you can have this out of your bloodstream relatively quickly, within a couple of days, for letting it wash out of your body. Now, there's other ways to block that CGRP pathway. One of them is something called a monoclonal antibody. Let me explain what these are for people online. A monoclonal antibody is a gigantic proteinaceous structure, huge protein structure compared to the tiny tablet medicines you're familiar with. So if you look under a microscope at the chemical structure of, say, amitriptyline, it's going to look 1/1500th of the size of these new monoclonal antibodies, right? These monoclonal antibodies are designer therapies. They take this big proteinaceous structure and they change an itty bitty bit at the tip of it to make it do what we want it to do in the rest of the body. That's why you've seen monoclonal antibodies in disease states like arthritis, and you've seen them in disease states like people who've got a lot of eczema in their body, or even in cancer therapies, but they've designed these special ones for migraine. And these were with migraine in mind, under the geeks under the microscope came up with the therapies to block CGRP. We've got 4 of them now that use this monoclonal antibody concept: arenimab, fremanezumab, galcanezumab, and neptanezumab. Don't get mad at me, Bill. I'm going to use brand names because I want to make sure people know what these are, right? This is going to be Aimovig over here. This is going to be Ajovy. This is going to be Emgality, and this is going to be Vyepti. These guys are once a month do-it-yourself injections at home. This guy is a once every 3 months IV infusion, and they got certain bells and whistles and accoutrements to each one of these. But the neat thing is, as a class, these medications are better than the tablet medicines at dropping frequency of headache, dropping severity of headache. Now, I guess the newer CGRP tablet medicines have a statement about that, but if you compare these once a month injection type medicines to the tablets before 2020, the ones I did my first couple of minutes talking about, these guys have better reductions in migraine days, better reductions in headache, And the side effect profile is really reassuring. There is a chance of having hypersensitivity and an allergic response to it. There's a chance of having a spike in blood pressure shortly after you start one of these medications. There's a chance of constipation that got flagged in one of these medicines that people like me and Bill think might affect the whole class of these medicines. We're still trying to get the data for that out there. And so we think that overall, these are relatively safe medications. And my goodness, have they been effective in the patients I take care of in my clinical practice. Not everyone responds, but those who do tend to do really, really well. In our practice, if someone does well, we take credit for it. If someone does poorly, we blame our fellow. These are just slides showing that if we compare the response rates from topiramate and propranolol, what's published before in the 1990s and 2000s, to the data that we see for people on these CGRP once a month medications or once every 3 month medications, these medicines perform better at dropping migraine days. We know this in the episodic migraine family. We know this in the chronic migraine family. So these are worthwhile thinking about with your clinicians out there. How about this one? This just looks at functionality. If someone's on these medicines and they respond well, you can continue to have a reduced risk of disability or less impact in your day-to-day functioning of life on these therapies. And this data is what makes me feel good at night for the patients who respond well to these therapies. So how about people who want to do something a bit different, right? If they're not interested in what you're telling them, you got to try something different. You got to convince them to do something different. We have ways to do that too. So one last thing I want to spend some time on, and only because I want people to pay attention and do what we say, but because we've got a couple of new things related to this post-COVID headache, I just feel like the need to mention. Here's our autonomic nervous system one last time. I got 3 more minutes and I'll be open to questions. All these tiny dots, one of the world's most famous migraine researchers, the great Rami Burstein, put out this article, and every tiny one of these orange dots in the brain represents something related to our autonomic nervous system. Now, our autonomic nervous system controls our blood pressure, our heart rate, but also the signal to blood vessels to expand and contract on the lining of the brain. Our autonomic nervous system also makes pain nerves more irritated when the autonomic nervous system is revved up, which means people who don't sleep well are more prone to generate migraine attacks. People who don't eat well are going to be more prone to have a migraine attack. People who are stressed out are more prone to have a migraine attack, or people whose nerves have been irritated by viruses or by other types of things may blossom into a persistent headache syndrome. And the thing about this is that Bill talked a bit about anxiety and how this relates to migraine. We know if you've got a diagnosis of migraine, you have a 4 times higher chance to develop anxiety later in life. But we also know if you've never had migraine before, but you have a diagnosis of anxiety, you have a 4 times higher chance to develop migraine later in life. They share the same machinery in the nervous system. And the famous medicines for acute migraine like triptans are serotonergic targeted medicines, just like some of our antidepressants. It's just a slightly different area of the serotonin pathway that they use. And people who've got migraine have evidence of autonomic sensitivity in their body because their skin changes color in their hands or feet sometimes. They're more sensitive to temperature changes, they're more sensitive to weather barometric changes, they're more sensitive to any irritation in their body. And you can measure this because people with migraine are more likely to faint in their lifetime than people who don't have migraine, more likely to have funny heartbeats, more likely to have all kinds of autonomic markers I don't even have time to mention to you about. And this brings up one of my favorite structures in the body, the 5 millimeter sphenopalatine ganglion. And this is the honey hole that regulates the autonomics in our skull. And it turns out if you put a tiny drop of numbing medicine right on this lining of the nose nerve bundle, you can suppress this guy for a while. And we see this help prevent migraine. Let me tell you how you do this, right? There's this thing out here, a device we use in our practice. It slides in the nostril and it dribbles numbing medicine onto this area in the lining of the nose. And if you can put numbing medicine onto the spot that coordinates this autonomic effect, you can improve headache in some people, you can improve autonomic symptoms in some people. And there's cardiology articles that talk about heart rate variability being improved or reducing fluctuations in blood pressure for people getting this treatment. But I like the ones that talk about the ability to reduce headache. So how about this? This was a study out of the UCSF, a fancy headache program in San Francisco. And what they found, if people received ongoing intranasal lidocaine using these types of devices, they had reductions in headache frequency, headache severity, and less medication use. And each treatment lasted about 3 to 3 months or so, give or take. So I bring this up because in our people who've got COVID-related persistent headache, we see a lot of autonomic symptoms. And we do things we can try to prevent migraine or headache in these people, but sometimes we try to target the autonomics with this, not just that numbing medicine, which is what this article talks about from people recovering from long COVID, but also medicines like prazosin, which is a sympathetic nervous system blocking agent, or kind of like a anti-adrenaline medicine. And we use this for daily headache in some of our patients. We use this in people who've also got PTSD and daily headache. Another issue we see comorbid sometimes in really, really refractory headache syndromes. And the last thing to mention is one of our friends, low-dose naltrexone. There's not much research in the migraine community with low-dose naltrexone. But here's the thing, it can help regulate some of the hormonal cascade we think that's disrupted in recurrent headache and centralized pain. And we also think it can lower an inflammatory piece of that puzzle. May not be helpful to everybody, but sometimes helpful in our practice. So if you're looking for newer, different ideas for people with really, really refractory headache, perhaps you look at low-dose naltrexone. Perhaps you look at this prazosin. Naltrexone is really, really inexpensive. In our practice, we prescribe the 50 milligram tablet that costs literally nothing in most insurances, or $4 for some people. You break it in half, you break it in a quarter, you take a quarter or a crumb at nighttime. Sometimes it's helpful, something worthwhile to think about with your providers. So that's about what I wanted to cover for today. Just a few things I just need to just reiterate before we go into our question answer. This guy sets the world record for jumping at the highest out of a hot air balloon. He's actually almost out of space, wearing a spacesuit with oxygen. He breaks the sound barrier as he goes down. My point here is don't be afraid to dive in. If you've been afraid to access care for migraine, we've got good tools out there now. We've got ways to help with this. So diving in might feel scary, but there's ways to get effects from this. Migraine's common. We know medications can be effective in preventing migraine. We know CGRP, this new concept of migraine prevention therapy, has been remarkably helpful for some people in the migraine space. And also be aware of autonomic dysfunction for people who have a lot of migraine burden. You start seeing some of these symptoms in the body. There's ways we can treat that a bit different than we do just regular migraine. So with that, let me open it up for questions. I know there's a bunch, and Bill can give his opinion on some of the stuff I shared too. I'm going to stop sharing now and we'll go from there. The guy does land safely, by the way. So if you're wondering at home, he lands completely safe.
Okay, good. Wow, that's a lot of information. My eyebrows still aren't raised either. So I'm just curious, a show of hands, if you have the ability and you're in the audience, if you want to raise your hand, if you are not seeing a headache specialist, just out of curiosity, if someone's not being treated by a headache specialist, I'd like to just, for my own information, I know Dr. Young, you would find this interesting. I'm sure you would too, Dr. Cooper. So I see a lot of hands going up. So interesting that how many people are, I guess that's why you're all here today. So let's jump into the questions. This is something that comes up quite often, barometric pressures, or anything folks can do to prepare for it. Any suggestions around that?
Well, I'll go first. Appeal your insurance if you move to Southern California. So far, no insurance is paid for that, but it's worthwhile thinking about at least. Now, I'm just joking. We don't have any easy fixes for that. And unfortunately, weather sensitivity, barometric pressure change is a multitude of different things happening at the same time. There's certainly a component of inner ear distress we think that occurs with this, but there's also a lot of responses deep in our bodies, such as our hypothalamus, and our thalamus is part of this. So it's hard to get in front with one treatment. I know there's a question about earbuds in the chat, and I don't see any harm in trying that type of an approach, but I also have limited faith in its ability. I'm sure Bill's got some wisdom to drop on us. What do you think, Bill?
There's a bunch of freezing going on with my computer, but I think that people who have unstable autonomic nervous systems, you'll do much better if it gets addressed. With anything that works for that will make treating your migraine easier. That's my main observation. And then you can pick medicines that are less likely to mess up your autonomic nervous system. I think sometimes preventives do, and it makes treating those patients, sometimes we have somewhat fewer options. I'm suspicious, I'm hopeful that the vagus nerve stimulator in the neck may be particularly useful for some patients who have autonomic dysfunction.
Okay, Great, thank you. Can you speak to, Kara has a question about tolerance to CGRP inhibitors. What do you say to that?
I mean, I'll start. I think it wasn't in the studies, but I think I'm seeing it in a few of the patients that I treat. And I think that that's a problem with clinical trials. And sometimes, they have so many restrictions on who can get in that they might not exactly resemble the patients that I have to treat, that I want to treat. And the ones that I do sometimes do seem to develop a tolerance. I'm not sure though. It's a surprisingly hard question to answer.
Yeah, I'll just jump on that too. We've seen less of it than I was expecting so far. We're now, 3 years in, as of May 18th, I think we're 5 years in, May 18th, for having experience with these medications in the clinical setting. And we see some of this. I'm with you, Bill. We see it sometimes, but it's less of an issue than I thought it was going to be. And there's two flavors of wearing off. There's the wearing off that occurs between each dose. And so we know some of our patients are more vulnerable if they're on a once a month monoclonal antibody. Sometimes they say right before my next dose, I'm more vulnerable for breakthrough headache. And sometimes we'll bridge them with their acute therapy. Sometimes we'll pray and shaman drum to hope it doesn't occur next time. But that happens. And then we see less of someone saying I was great for a year, now I'm not great. That's less. And I think many providers at that juncture would likely swap over from one to the other and see if we can get a slightly different area, because these medicines aren't exactly the same. They actually work slightly differently on the receptor of where they're working on, or the ligand of what they're working on. So there's a little bit of variability. So sometimes swapping from one to another would make some sense.
Okay.
I have another observation that may be too much, but we've always seen pill medicines that seem for some people to become less effective in time. We saw that with topiramate and perhaps some of the blood pressure medicines and so forth in the past. So it's not too surprising to see it with any preventive. And I don't think that the CGRP medicines, if they have this phenomenon, are any worse than the older pills at having, less effect over time. I think the one exception, is Botox.
Mm-hmm.
I think I have people who did well for 3 years, and they did great the 3 years after that, and they did fantastic the 3 years after that.
Good point.
Okay. All right, we're going to move on because we still have 40 questions here, so we're not going to get to all of them. Do you want to talk a little bit about medication adaptation headache, rebound headache? This person's doctor had them go off of all their medications, and it was not an easy thing to go through. So, yeah. What say you?
You want to take a crack at this, Wade?
Yeah, I do. And know that if you ask 10 headache neurologists this question, you get 11 different answers. So let me first share with you that I think talk about stigma. Unfortunately, I think rebound headache or medication overuse headache has been used to victim blame a lot of our patients. And that's my own beef about this. I also think it depends on the medication, and I know this is going to perhaps be a difference of opinion with other neurologists out there, but I'm not too worried about NSAIDs or acetaminophen. I think that we don't have great evidence that causes trouble in the nervous system. We worry about other reasons. I worry about effects in the body, irritating the kidney, liver, but we're far more concerned about the opioids, the benzodiazepines, and maybe a lesser extent of the triptan class medications. So if someone's coming to us and they're on a lot of barbiturate class medicines, that's like, your Fioricet type medications, I'm certainly worried about that. There's pretty good evidence that irritates the nervous system. You got to find a way around that. We have ways of doing that. Same thing with opioid medications. On that, which means we sometimes will transition to buprenorphine or phenobarbital or whatever we need to do. But to let someone fester without challenging that is a mistake. However, if someone's tried it before, gone a couple months off, didn't get any better, you don't have to try it 5 or 6 more times to prove that effect. So that's what I'll say, and I'll give Bill the hard part of telling what to do about it.
Yeah.
Well, you know what? I'm going to ask you to talk really quickly, if that's okay, Bill, because we have a lot of questions. So,
Okay, I think it does depend on the medicine, and the NSAIDs are much better. And some people get better in a few weeks, and others it might take longer. You cannot, in a population study, you cannot find people with frequent migraine who don't treat. Like, it's very hard to study because there's nobody who's not treating their migraine attack. It's such a horrible disease that you can't find a comparator group of people who have frequent migraine and aren't like taking something a lot. And we think that the CGRP medicine, thank goodness, don't seem to cause rebound. So the acute CGRP medicine seem to have like a special place if they work for you. Use them first, so you get less rebound.
okay. Here's a question that I actually like to hear from Lisa. She's asking, have you seen the impact of increased patient advocacy in your actual practice, either in your own practice areas or what you hear from other healthcare providers, especially providers who aren't headache specialists?
I'll take a crack at that. I think so. I think that, I get less of that kind of, comment that I used to get when I was starting out in headache medicine 25 years ago, 30 years ago, that I showed you at the beginning of my talk. And I think, I get a little bit less of the patient who comes in who's just like so ashamed they can't even tell their story, which I sort of used to see more of that. I think very hard to prove, but I hope, and I don't know if I'm just being optimistic or rose-colored glasses, but I think it's getting a little better.
Yeah, for the newer physicians I'm seeing, there's a little bit less of the negative stigma towards the patients. From that end, I think some of the science has helped. Some of the advertising that's been done through some of these large drug companies that affects physicians' thinking has been helpful. And I think we're seeing newer physicians wanting to go into the field of treating headache at a quicker pace, at a more rapid pace than we used to. And a lot of this is the advocacy that you as a group have been doing, as well as the great work from the superhero Bill Young.
Can you talk a little bit about the research around the migraine vaccine? Do you know anything about that?
I do. I know a little bit. I don't know what you know, Wade, but I just, as I understand it, it's a thing that's under study that they think is going to work, and it's against CGRP. So, it'll probably be similar, but imagine, you take a shot every 6 months or 12 months, and then when it wears off, you go back and get another one. And
I think we're years away from that too. Bill, you froze on Cecilia Thunder.
Schedule. And your body makes its own, arenemab or Aimovig. Your own body makes its own Ajovy for a while. That's how I.
Oh, okay. I think we'll keep going here.
I could lip read when Bill froze. He said Dr. Cooper's the best neurologist he's ever met in his life. I'm a good lip reader. I really am.
We have that.
Yeah,
we have that recording.
I also said I wish I could give a presentation the way he does.
All right, next question.
Okay, your opinion on further education on hemiplegic migraine, not only to people who experience them, but doctors in the ER.
I'll go quick on this one. That's a topic for a different day. There is a bit better understanding now, not just of hemiplegic migraine, but of a related issue, migraine with unilateral motor symptoms. And we see this. This is more clumsiness and weakness of an arm or leg where someone can't function the way they want to. We're looking at this now as a piece of migraine, but man, there's a lot of work still to do with this. And that's a discussion for a different time.
Okay, so part of a migraine attack, just before, during, and after having balance issues and hand shaking, is this something common?
Balance issues, very common. Hand shaking, sometimes, but that's not so common. That's how I would view it. It can be just a part of the migraine. So.
Yeah, and I just throw one more piece that I agree with everything Bill said, like usual. But also handshaking can also be a bit of the sympathetic overdrive, this kind of revved up nervous system. And so we would be curious about if there's other features of that. If this comes with an anxiety experience, if this comes with palpitations, my guess is yes, but I'm just guessing, obviously.
Okay, how does having MCAS affect the use of preventive medications like a CGRP med?
Can I go? I'm going to go with
Yeah.
this one. So I have a special interest in MCAS, and for those who aren't familiar, it's mast cell activation syndrome. And I had to cut out a whole bunch of slides as I was preparing for my 30-minute mixed session on this topic, because there's lots to share with this. And not everyone with migraine has mast cell activation disorder. It's really the idea that these mast cells are too active everywhere in your body, or many places in your body. But we do change our therapies a bit for this. You know, I'm a big fan of something called ketotifen. You have to compound it, but that stabilizes mast cells. We use that a lot in our people who match chronic migraine with mast cell activation syndrome. And we're happy to manage this just because I don't have much faith that our local allergists will do so. We use quercetin, which is a vitamin supplement that stabilizes histamine 4 receptors. And then there's a bunch of medicines we use in the migraine space that have mast cell stabilizing properties. I hinted towards that with the tricyclic medications. Interestingly, doxepin is my favorite of the tricyclics for this. And the allergists are trying to claim that they thought of that. I'm like, wait, we've been using that for decades. But yeah, so there's lots to know, and that is certainly a topic for later, but there's certainly a relationship. Mast cells are related to irritating the lining of the brain. They're in every article that talks about migraine mechanism. They just don't call it the same thing. So neurologists don't realize that these mast cells are what they're treating with migraine sometimes.
And then you had mentioned loratadine before. Does cetirizine work the same as that?
Yeah, cetirizine is over-the-counter Zyrtec.
Cetirizine.
Yeah, cetirizine is actually my favorite of the over-the-counter antihistamines to use. I don't use cetirizine for regular migraine prevention. So just to be explicitly clear, if someone's got regular migraine, I'm not whipping out cetirizine. However, if they've got the stigmata of mast cell activation disorder or on the spectrum of that, and that means that they have flushing episodes and sometimes a lot of abdominal symptoms and sometimes a lot of autonomic symptoms. And they have a list of 12 allergies. And they say, every time I take a medicine from you, it makes me feel sick and funny. We blame Dr. Young. And then we talk about this concept. Maybe they have mast cell activation syndrome. And in those situations, we talk about an antihistamine trial. We put them on higher doses of cetirizine than over-the-counter recommendations for allergy. We combine that with the histamine 2 receptor, which is Pepcid or famotidine. And we try it for 4 weeks and we see if they get better. If they're better, it suggests they may have it. It doesn't guarantee it. It's a helpful tool. And some people can have mast cell activation disorder and not respond to antihistamine therapy. They may respond to leukotriene inhibition, like we use singular off-label for that, or they may respond to prostaglandin therapies, or they may respond to mast cell stabilizing. So it's a discussion point. It's not an answer, but yeah, that would be something to think about.
Okay. Question. So let's go into CGRPs a little bit. There's multiple questions in here. Just going to lump them all together. So one is, if they stop working after 6 months, or how long should you wait to see if they're working? What if they stop working after a year? So this whole time of, when they stop working, and how long should you wait to see whether it's working? And then if you have gone through all of them, right? There's 6 now that are for prevention. Is that right? 6. So then what do you do?
So I'll go first, Bill, then you can chime in. Okay, so first thing is, how long do they take to start working in the first place? I'm going to separate these. The tablet forms of medications are relatively quicker, in my opinion, than the once-a-month injections. Now, the IV infusion, in my opinion, is as fast as my tablet preventive therapies. That's an opinion. I don't want to arm wrestle anyone over that, but that's my opinion about it. Yeah.
And then I can tell you why. It takes 4 or 5 days to travel, the shot to travel through the lymphatic system. It doesn't go to the blood. So you start, 5 days behind the pill.
Yeah, it's also a gradual onset with the sub-Q ones, and there's a reduced what we call bioavailability, meaning if you inject a certain amount, some of it doesn't even get used by the body because of its path to get where it needs to go. So the once a month subcutaneous ones, I think, take 3 to 6 months, and I don't stop people until I'm 3 to 6 months in to see if they're going to respond. If I have the IV infusion or if I'm on the tablet medicines, I'm expecting a response quicker, but I still want them on it for 4 to 8 weeks kind of thing to make a decision. Now the wearing off, we hope they don't wear off, and the bulk of my patients don't wear off. If they respond well to one, they generally remain responsive on that. No guarantee. If someone does feel like they've worn off, then I'll switch them, but know that it's going to take another month or two for them to respond to the new agent. That's how I'd explain that.
Okay. What do you say about, I think someone's asking about some questions in here about magnesium, and does IV magnesium work better than the pills? And what form of magnesium did you recommend?
Yeah, I'll do this real quick, Bill. So IV magnesium for prevention just doesn't make sense. So scrap that out of your mind. For migraine prevention, my favorite is magnesium glycinate, but it's a bit harder to find, a bit more expensive. My other favorite is magnesium oxide, and every pharmacy in southeastern Michigan sells magnesium oxide. It's about $4.20 a month. And if you go to a local chain right now in southeastern Michigan, it's buy one, get one free. So I would say magnesium oxide 500 milligrams a day is cheap and easy and probably as good as the other kinds out there. There's other types that have been studied, and Bill, I'm sure you have an opinion about it too.
Yeah, I mean, we looked at the absorption. We like malate and magnesium malate. It's just neck and neck with the glycinate. I think that the oxide is a little bit tougher on the stomach, but it's pretty good.
Okay. There's a question about migraine with aura. Are there any medications or procedures that help aura? And I guess, do you know about any research on aura where this person can look?
Go ahead, Bill.
There's a medicine called lamotrigine, which is a seizure medicine that appears to be, sometimes very good. It's absolutely useless for migraine without aura, and quite good for many people, maybe most who have aura. So in making the decision, if somebody's problem is 100%, they don't get, if I got rid of their aura migraine, but that's only 10% of their migraine, it's not worth a try. Try something else.
Yeah, I'll just build on that. There's a subset of people with migraine aura that develop a more intense type of aura as they mature, or 50, 60-year-olds who said I had migraine when I was a younger person with a lot of headache. Now the headache's less of an issue, and now the aura is driving me crazy. Those are my ones that I look at this lamotrigine medication for. It takes a while to build up on that medicine, but it's my absolute favorite if someone comes in and their main beef. When we ask our new patients, what does victory look like? And if someone says victory is less migraine aura, then I'm most likely going to put them on lamotrigine, and I'm most likely going to put them on a methylated type of vitamin B complex.
And some people, verapamil, which there was a question about verapamil, we don't think of as a very good preventive for migraine without aura, but it may be a little bit better for migraine with aura.
Okay, do you want to talk a little bit about affordability, people that are on Medicare, for example? I'm sure you have a lot of patients that are Medicare patients. What do you do?
I mean, the CGRP pills, it's absolutely hopeless. I don't even like to mention it because, they get a $500 bill and they're enraged. It's like, it's awful. And unfair. The monoclonal antibodies are expensive, but people can somehow handle that more, some can't because they don't have the means. Botox is a little bit more affordable for people on Medicare. And then you got to know your pills and what's generic and not generic and so forth. But most generic pills are not a big burden for people on Medicare.
Yeah, I'm with Bill on this. Our Botox tends to be easiest financially for our Medicare patients. And then I'm going to speak just for our region, I guess. But sometimes the IV form of the CGRP blockade goes through medical benefits and not pharmacy benefits. So people look at it as a hospital copay as opposed to a pharmacy copay. And so that's our workaround. It doesn't work for everyone. And it's beyond me to understand the intricacies of Medicare and how some people get it covered and some people don't.
Yeah,
My success rate.
Smart.
Yeah, normal, no, right. But my success rate is better for the IV form of that medication than it is if I'm trying to get someone on a once a month or a tablet, as Bill had mentioned.
Okay. Oh, here's a good one. What do you think of the psilocybin research for migraine?
Rudimentary. Um, you know, we're we're I won't speak for we, I'll speak for I am hopeful. You know, I don't think it's going to be quite as good for migraine as cluster, but it may have some role. It's way early and it's way tricky for doctors to talk about that, you know, without worrying about getting thrown in the slammer.
Yeah, I think it's an opportunity. I think as it stands now, to grow your own shrooms and to try to use the psilocybin that way or try to get them from other people is hard to do. And, you can get it compounded in Connecticut, I believe, but I can't get it in my state kind of thing. But the thing is, as we learn more about this, we might be able to develop better tools that don't have the stigma and don't have the same downside as psilocybin. So to me, it's an opportunity as opposed to a solution for migraine patients.
Yeah, DHE and an old headache medicine called Sansert or methysergide are chemically related to LSD and, you know, indirectly chemically related to psilocybin. And they work on the same receptor that is a type of serotonin receptor that may be very important opportunity for helping people with bad migraine disease.
Right. What Bill said.
Somebody's asking, do you see patients virtually? I know you do, Dr. Young, but do they have to come into your office first?
First visit has to be in the office. You know, after that, if our patients, the problem is we don't have, you know, 50 state licenses. And so it is hard to be a good doctor to, you know, a person with a challenging headache disease who's 10 states away and I don't have a license in their state.
Yeah, that's an issue for us in the state of Michigan too. I can care for anyone virtually in the state of Michigan, but as soon as I'm in Ann Arbor, and if someone's 1 mile south of the border, technically I should not be in a virtual visit with them because I'm not licensed in Ohio, the state shaped like an armpit. So what can I do with that?
Okay. What about, I know we're over time. We're just going to ask a few more questions and then we'll have to stop for today. And I did actually put the link for the survey. If you could go into the chat, if you're still with us, it'd also be emailed to you if you don't want to do it right now. If Toradol helps but upsets the stomach, is there something similar? Ibuprofen does not help.
I'll just talk out loud about this for a second. There's tablet. These are all things you can talk to your provider. They're not trying to give you any direct medical care. But in our practice, we would consider using tablet ketorolac. I know it gets crummy reviews as how well it's absorbed, but you can double dose it sometimes under a physician's guidance and sometimes more effective. There's also a nutraceutical called Boswellia that we use that has an anti-inflammatory effect that can be used for some people. And then there's also a few other prostaglandin targets. There's a liquid celecoxib that's going to come back on the market and sometimes use other COX-2 medicines like meloxicam, which is brand name Mobic, that can be used sometimes too. But these are great topics to discuss with your local physician. I don't want to be giving you direct advice.
Okay, that's good enough. Someone's asking about the Botox causing tolerance. I think you said that's not possible, is it?
I'm not going to say it's not possible, but you see less tolerance to it. You can get an antibody where it stops working and it doesn't actually, you know, block the muscles. You can raise your eyebrows about the Botox at that point. But you know, if it's affecting the muscles, you probably won't get a tolerance.
Okay. What about any suggestions around how to handle a severe migraine attack without having to go to the ER?
I'll take a crack at that. You know, you need to be creative. For some people, you have to go around the stomach. You just have to recognize pills are going to work. You have a shot of something, a suppository of something, and maybe a nasal spray of something. You have to make combinations. So, you know, some combinations are safe. And others are, you know, like absolutely not. So you need some help with that, and you should have, you know, you may need to do more than one thing. One thing may just not be strong enough for some migraine attacks.
Is there a best OTC medicine for nausea?
Ginger? I don't know.
No, I haven't found one.
Okay.
Unfortunately.
And do you want to make any comment to Jim is asking, care to comment on CGRP of effectiveness on male versus female patients? Is there any difference?
Yeah, so I know that I'm familiar with at least one of the data sets that did look at men and women separately briefly, and there's no real difference in outcome, but there's far fewer men in the clinical trials than there were women. So it's hard to make any inferences with that. As of now, we think they're relatively similar. That's my opinion, at least.
Agreed.
Okay. All right. Well, we're going to have to stop there. There's a lot
Oh,
more
wait,
questions.
I have one last question.
Oh, yes.
One last question.
ahead.
Bill, do you have ripped abs and stretchy biceps that screech out your red costume?
Yeah, my abs are shameful, and spandex I have never owned.
So
Well,
he
let me
says,
say this.
only a true superhero would deny that.
If you come to the Philadelphia Miles for Migraine walk run, maybe he'll show us. So
There you go.
that's an
Yeah,
incentive
I
for
have
everyone
hair
to show
that
up
can
there.
turn purple, but I don't have abs or muscles or anything like that.
I'm just playing with you. Bill.
Well, I want to thank, laughter is the best medicine for migraine, that's for sure. Want to thank both of you for being here today. It was very informative. And I want to thank our sponsor again, Teva Pharmaceutical, for sponsoring this event. And we hope that you learned something here today. This has been recorded, and you will get a link to the recording. And please take a moment to complete our survey, and also become a volunteer at Miles for Migraine. It's really the best way to feel better about this disabling disease, is to be with other people just like yourself. And also to reduce stigma, we need people to stand up and really make a lot more noise. So again, thank you, everyone. Have a great rest of your Sunday.